I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Welcome, everyone. Those of you who are able to join us today during our lung cancer living room. I'm Danielle Hicks. For those of you who might be new here, I'm Chief Patient Officer at Go-To Foundation for Lung Cancer. For those of you who are new and maybe aren't familiar with our living room program, it is a support and education series created specifically with patients and caregivers in mind, with the ultimate goal really of bringing to you live and in real time educational talks from key opinion leaders such as the one we have with us here today. For tonight's topic, we're going to be discussing resistance to targeted and immunotherapies and what happens next. I know this is a huge question that we get, even for those who maybe haven't generated any sort of a resistance. They want to know, like, what's their plan B, or sometimes even their plan C. So I am happy to say that tonight we have Dr. David Gandara, who is Professor Emeritus, Co-Director, Center for Experimental Therapeutics at UC Davis Comprehensive Cancer Center. And as I said, a little earlier, a lot of work has been done really in the past decade and a half in researching and discovering biomarkers and appropriate therapies that directly target them. So tonight we're going to talk a little bit, or a lot of it, about resistance to targeted therapies and immunotherapies, what it means, and how to treat it. And who better, in my opinion, to do that with than Dr. David Gandara. So like I said earlier, our main focus is going to be for those of you who have already had maybe an identified biomarker and have been on a targeted and or an immunotherapy, and you're worried about resistance, or you're facing resistance right now. And I think before we jump into just talking about it, we should maybe talk a little bit about what resistance is. So Dr. Gandara, can you explain to the folks watching tonight what we mean when we say resistance?
Well, I think the simplest way to think about this is to think about an infection and how some infections become resistant to antibiotics. In other words, maybe initially it was sensitive and the antibiotics killed the bacteria, let's say. But then after a while, it becomes resistant to the antibiotic, and you may have to switch to a different antibiotic. So number one, this is an analogy, which Danielle knows I love. So cancers are not infectious. You're not infectious to anybody else, but it is something that people are familiar with. They know about drug-resistant infections. Well, cancer can do the same thing. In other words, a cancer can be initially sensitive to a treatment. That treatment ordinarily would be called a targeted therapy. In other words, targeted against whatever abnormality, mutation, something else that's in your cancer. And then after a while, and those of you that might have an EGFR mutated lung cancer or an ALK translocated cancer, and we could list a whole host of these, all the way to the new things we'll talk about later, like HER2 mutated. But at any rate, if the cancer is not all killed, and hopefully it would be, but very often it is suppressed, even for years and years. Danielle and I have patients in common where they're on year 14 or year 16 or something. But eventually, a lot of those cancers become resistant. So that means that the drug they started you on is no longer working. I have little analogies for all of these things. So the one I use for this situation is that there's a lock and you have a key, and the key opens the lock. So the lock is the cancer, the key is the drug. It's successful, opens the lock. And then some time goes by, a few years, and you go back and you try the same key. It doesn't work anymore. Somebody changed the lock. So it's a very simplistic way of thinking about it, but it actually resonates, I think, not only with patients, but with doctors. I tell other doctors, this is how I explain this. So at any rate, you need a new key. So the new key, let's say if this were a oncogene-driven cancer, an oncogene means usually mutated or translocated. In other words, these are the things that you all know. These, are ALK and ROS1 and BRAF and so forth. So at any rate, you find a new drug that can open the lock and you're on your way. You get another remission. So in short, that's what happens. Now, the analogy I just gave is about what we would call targeted therapy. But tonight, Danielle and I will also talk about immunotherapy. A lot of you may not be candidates for targeted therapy. You may not have one of those oncogenes in your cancer. But the same sort of thing can happen with immunotherapy, and we'll talk about that.
That's great. And I am, as you stated, very familiar with your analogies, and I love them. And as I've told you in the past, I have stolen them from you to use with people that have been diagnosed, call the helpline or are checking in to see about, how we might be able to help. So I, for one, very much appreciate your analogies. Before we jump into talking about what you initially, referred to as what are these oncogene drivers? In other words, what sort of mutations might or biomarkers might we be able to find in a person's tissue or blood that has an FDA-approved targeted therapy associated with them? And then, like you said, we're going to jump into immunotherapy. But before we do that, I want to touch on something a little bit that I know you and I have discussed previously and probably years ago at the Lung Cancer Living Room, but there's a little bit of difference in how we identify and treat what is a true progression of disease versus what is called an oligoprogression. Can you explain a little bit the difference between those two and how and why they might be treated differently?
Well, that's a great point to discuss, Danielle. So there are a bunch of progressions, right? So actually, let me address the pseudo first because that's the most confusing to patient. Then we'll talk about oligo. So progression, and the term progression means the cancer got worse. Now, most of you may know that, but I've had patients who come into my office and I say, I'm sorry to tell you this, but your cancer has progressed. You have progressive disease. They say, thank goodness that they think progression is like it's progressive, it's good. So in this context, the term progression is bad. That means in general, the cancer has either grown or it has spread to new areas. The term pseudoprogression means, like pseudo, it looks like it's progression, but it's really not. This is most pertinent not to the oncogene-driven cancers, but to patients getting immunotherapy. And it is most often seen in a different cancer than lung cancer. It's seen in melanoma. Occasionally, it does happen in lung cancer. And the reason that it happens, pseudoprogression means that you do a scan. Your oncologist gets another scan after 2 or 3 months, and it looks like at least some of the cancers, if there are multiple areas, are bigger. Now, ordinarily, we would say that's progressive disease, that's bad, we should go on to another sort of treatment. However, pseudoprogression means that the way immunotherapy works, that there are your own T cells that are reacting against the cancer, and they go into that area, and because they're causing a reaction there, inflammation, it looks bigger on a scan. But it's really the first step toward a response or a remission. Now, how do you differentiate pseudoprogression from true progression? By and large, it's by how the patient is doing. So if I ever see something like in lung cancer, which again is rare, what I say is, how are you? And the patient says, gee, feeling great. I was having pain in that area. It's gone now. And I'm eating better. And now I'm out, able to go exercise and go get groceries and so forth. That makes me think it's pseudoprogression. On the other hand, if I see that same increase in the cancer on a scan, and I say, how are you doing? And they say, well, I'm not really doing well. My pain, is not any better. If anything, it might be worse, and so forth and so on. Then I know it's true progression. So we use the clinical symptoms. Okay, so that's one kind of progression. So Danielle mentioned oligo. Okay, so oligo is even more complex. Oligo means a few. So when somebody has progressive disease, very often it's in lots of areas. In other words, the cancer got worse, and if there were places in the lung, that got worse, and if there were places in the bones, that got worse, and it could be either an increase in size or new areas, like new bone metastases. In some patients, though, it's only a few. Now, originally, this was one area. Now it has ballooned. And I think I'll have to say this, Danielle, in an irresponsible way. Could be 15 areas. To me, that's not oligo, that's systemic. But let me explain why it's important to those of you listening. And this is really mainly for the oncogene-driven cancers, EGFR, ALK, and so forth. Let's say that you're on a treatment for that kind of cancer, and it's a year, you've been on it for a year, you're doing great, you're feeling great, and your oncologist sees one area that seems to be growing significantly, but it's only one. Well, in that case, we call it oligoprogression. And these days, in 2022, we know that in some patients, if you treat that one area locally, and most commonly this is done with radiation, a focused sort of radiation, one of the names for it is SBRT, stereotactic body radiotherapy, that if we zap that area, that is where the bad actors are coming from, the resistant clones, that you could stay on the same treatment and maybe do well for quite a while. It is a guessing game because sometimes you see the one area and you say, oh, well, thank goodness it's only one area, I'm going to zap it. And you give the stereotactic radiation, and then you do the next scan, you keep the patient on the same treatment, and then 3 months from there are 5 new places. So in that case, you really didn't benefit the patient. On the other hand, what if there's that one area, it gets SBRT, and then the next scan, and the scan after that, and the scan after that continue to look good with no further progression. In that case, you've benefited the patient. The problem is we sort all these things out through clinical trials. And every patient is different. So if you do a clinical trial looking at alloprogression, you're going to have this mix of patients. Some they have systemic progression. You just can't see it because our scans are not micro level, right? It has to be about as end of the big of your end of your small finger for it to be seen on a scan. So it's a controversial area about how far to push local treatment for oligoprogression.
Yeah, no, I appreciate your explanation of it. And I think it kind of points back to everything we talk about in this meeting all the time, right? Like the science and the clinical trials and how important the research is. First of all, I want to stop and say the biology and the human body never cease to amaze me. But that there's still a lot that we don't know, right? That you and folks like you who have spent your entire careers trying to find out. And we've done a really great job in the last 10 or 15 years as it comes, as it pertains to lung cancer. But there's still so much we don't know. For example, in this oligo space, why using radiation therapy to target the one oligo sort of spot works for some people and not for others. We just don't have all of the answers yet. But I think it also points back to something that we talk a lot about in this meeting and in other, patient programs and really across the board, is why it's so important to educate yourself and then to be able to have these conversations with your doctor so that you can be part of the decision-making process and understanding, what best next steps are for you.
The better scans get, the fewer times we think it's oligometastasis. Just as an example, we have a scanner at UC Davis. There are only 2 in the world. It's 100 times more sensitive than a regular PET scan. It's called Explorer. Sometimes we think a patient has oligoprogression because we've gotten a regular PET scan, and we do the Explorer, and it shows 10 areas all over the body. So again, the better technology gets, it's like everything else in the world. The better we get in finding things, the more we can direct patient care for what we would call precision oncology, something individualized to that patient.
Yeah, I agree. It's a multifaceted approach, right, to treating patients, and the technology and the diagnostics are an important, a very important piece of that. So we talked a little bit about what is resistance, what is progression, the different potential pseudo and oligo progressions. What we didn't talk about was like before that, right? So assuming that the folks watching already know, and they've already had their biopsy, a target has already been identified. They're either on a targeted therapy or an immunotherapy. So let's say we've decided this is actual progression and we need to figure out what we're going to do next. Why is it an important next step, in your opinion, to rebiopsy this cancer to see what's happening and what best next steps might be?
Okay, well, here we have to define things a little more as well. For those patients that are on targeted therapy, because they have one of these drivers, these mutations, these oncogene drivers, then looking at the time of progressive disease to find out, why did the cancer become resistant? It was sensitive before, it's been sensitive for, let's say, 18 months. Why did it become resistant? And the reason is, in 2022, our next treatment may depend on what caused the cancer to become resistant. If it's immunotherapy, it's a very different situation. And I would say it's less defined that a rebiopsy would point you in the right direction. So I know some patients will say, well, Dr. Gandara, I heard you say we always need to rebiopsy or maybe get blood, circulating tumor DNA, to find out what the mechanism of resistance is. And you said, in my case, we don't need to do that. I'll say, well, that's because you're on immunotherapy. It's a different kettle of fish. But let's start with the targeted therapies. And again, just because it's the most common, let's start with EGFR mutated lung cancer. So these days, in the United States, we're very fortunate. We have a drug called osimertinib. I'm not going to say the brand name because I would have yellow tape put on my door by the University of California if I used the brand name, but OSI. So OSI is what we would use first line. I'll just tell you, only 40% of the world has availability of this drug. Some countries have approved it, but it's not reimbursed. So that means it's sitting on a shelf in a pharmacy, but you can only get it if you pay for it out of your pocket. So, our medical system is messed up. It's not fantastic, but at least we have access to these therapies. So let's say that you're a patient that's on osimertinib, and this was your first treatment. In other words, you didn't have something else before. Osimertinib is called a third generation EGFR TKI. Well, that means there was a first generation, there was a second generation. So, usually when you think, oh, third generation, that must be improved. It is. The mechanisms of resistance to osimertinib are different than if you had gotten one of these first or second generation. And I'll just give some names. One of them is erlotinib, that's a first generation. One of them is afatinib, that's a second generation. So you have to know also that it's different. Osimertinib wasn't developed to be given first line. It was developed to be given second line once you had failed one of these other drugs, because it was so fantastic against this resistance mutation that 50% of people had when they got erlotinib or afatinib, and that's called T790M. Then, when we found out how effective osimertinib was, and also that it was better tolerated, it went into clinical trials, and the key here is one called FLAURA, where osimertinib beat the other first-generation TKIs, including improved survival. So that's how in the United States we got OSI first line. Let's say you're on OSI first line, you now have systemic progressive disease. So you could do that one of two ways. You could either rebiopsy the cancer, and if we do that, we tend to want to biopsy something that's actually growing. You don't want to biopsy something that's still in remission because it may not have the resistance mechanism in it. Or these days, in many cases, we can use blood because every cancer sheds some of that tumor DNA into the blood, and we can detect it now in blood specimens. That being said, there are some patients that do not shed into the blood. We call them non-shedders. So you may have to do a biopsy. Let's say you do one or the other. The chances are you will find something that has caused the resistance, but it could be 20 different things. Some of them are more common, some are less common, some are highly treatable. So one example, and I think we may come back to this later, so I won't elaborate, Danielle, is something called MET amplification. So here's another gene, MET. So I call it a dancing partner. Again, I use these analogies. So, the original person, the dancer, had the EGFR mutation, and the dancing partner now that joins the EGFR is MET. We have fabulous MET inhibitors now, and very commonly, I recommend that we don't have to give up osimertinib and go to chemotherapy or whatever. We can actually continue the OSI and add a MET inhibitor to it, and the success rate's pretty darn high.
I do want to start talking a little bit about, though, the actual resistance to targeted therapy. And we've talked a lot about EGFR and osimertinib. And, you've already sort of, outlined for folks watching that the osimertinib has been shown through trials and studies to be superior to some of the more, earlier, drugs that were approved. But people do still resist on this therapy. So in spite of the fact that it is the standard of care first line, what happens next? And in particular, if you can talk a little bit about the CHRYSALIS-2 trial, what's going on there and how you personally are utilizing some of that information.
So that's a lot. And this trial is about a new drug called amivantamab, which was approved about maybe almost a year ago, 10 months or so, for a different kind of EGFR mutation, one called exon 20 insertion. So for most of you who are on this call, you don't have this. Some of you may, but it's a mutation in the same gene, EGFR, but it's what we call non-sensitizing. And so in a general way, that means if your cancer has this mutation instead of the typical ones like exon 19 deletion and L85-8R, you'll know those terms. If you've got one of these oddball, exon 20, shouldn't call it oddball, but if you've got that mutation, then the EGFR TKIs like osimertinib don't work very well. And in fact, chemotherapy works better. So amivantamab and another drug, mobocertinib, and several others that are coming down the road are specifically designed to be able to hit this mutation. So this amivantamab is one of them, and it's FDA approved for exon 20 insertion mutations. Now, that being said, it's also pretty good against the regular mutations. And what it is, it's a monoclonal antibody. So if you think back to breast cancer and you think of trastuzumab, and I'll just say the brand name is Herceptin. So I didn't say it out loud. So at any rate, a monoclonal antibody is a manufactured antibody against something on the surface of the cancer cell, the receptor. And in this case, this amivantamab not only hits one of these receptors, it hits two. So it hits the EGFR receptor, and then it also hits a receptor called MET. Remember, I mentioned earlier that MET, M-E-T, is a common cause of resistance in EGFR mutated lung cancer, the sensitive types. At any rate, the drug is approved for exon 20 insertion, but clinical trials have shown that giving amivantamab with another experimental oral drug, in other words, so more like osimertinib, and it's called lazertinib. It's not available clinically, it's research. That at the time you fail osimertinib, and I shouldn't say that, the time osimertinib fails you, if you're the patient, then giving this combination of AMI plus laser can be quite effective in getting another response. Well, unless you're in a clinical trial, you can't get laser, but you can get amivantamab if it's an exon 20. So what some of us have done is if you can get amivantamab, you can give it and just continue the osimertinib. So in other words, you have progressive disease on osimertinib, you just stay on it and you add AMI. Now, that's not a standard of care. That's not in the guidelines, but that's the reason Danielle asked. Because until that combination or something else comes out, if you have the classic EGFR mutations, this can be a good treatment. Now, it's one of many, and you could switch to chemotherapy. You could even give immunotherapy, although it's not very effective in EGFR mutated. But this is a potential option if you can get that drug.
So, yeah, no, it's exactly why I asked. And I think MET has come up a couple of times, and it's a common sort of bypass mechanism in lung cancer, correct?
Yes.
So another sort of early phase trial, Teliso-V, showed some initial sort of positive results in treating non-small cell lung cancer with c-MET overexpression after developing resistance on osimertinib. Can you talk a little bit about that?
So it is a MET inhibitor. And since MET is it's the most common bypass mechanism, we call bypass. Let me just explain that real quick. If you have, and this is not just EGFR, it could be ALK, could be ROS1. If you have progressive disease, systemic progressive disease, the mechanism of resistance tends to be one or the other. One would be it's a secondary mutation. Remember I mentioned T790M, that's the classic here. But there are like a dozen of these, or 18 or 20 for ALK, for example. So it could be a secondary mutation. We call that on target. Or it could be a so-called bypass. That's what we call off target. So what that means is the cancer became resistant, not because another mutation came up in that gene. Something else happened, which made it resistant. MET amplification is common, but patients could also get other kinds of things, other mutations, but they're not related to EGFR in that example. So at any rate, yes, this is common, and Teliso and several other drugs against MET can be used in this situation. And we use these in the clinic. And the reason I say that is some of these drugs are already FDA approved for MET-driven cancers. There's a mutation in MET. Some of you patients on the call tonight might have this in your cancer. It's called the MET exon 14 skipping mutation. At any rate, since the drugs are FDA approved, I typically have not had problems getting those drugs reimbursed. And again, you continue OSI, but you add the MET inhibitor.
I think just to kind of go back just for a second to these on target mutations that we talked about. I know this is particularly important in something like an ALK, a patient who is diagnosed with an ALK fusion or mutation, where there are several generations of ALK inhibitors out there. And one of the reasons folks can flip from one ALK inhibitor to another is because the mutation actually happened on target within the ALK sort of space itself, as opposed to something else you're talking about. Correct? Can you explain that?
So I'm going to give my same answer. It depends. and ALK is a little more controversial here compared to EGFR. Should you just pick the next ALK inhibitor off the shelf and just switch the patient from drug A to drug B? Or should you do a repeat biopsy or liquid biopsy and see if you can find the mechanism and then gear your next treatment toward that? So when I asked our audience at Huntington Beach meeting 2 years ago what they did, the majority of people said, we just picked the next one off the shelf. We asked the same question again this year, and over 50% said, no, I want to know what the mechanism is. And I'll just give one brief example that one of these ALK third generation drugs, if the mechanism of resistance to the prior ALK inhibitor was on target, then this drug got a response in 70% of cases. If it was off target, the response rate was only 27%. So in other words, it can be useful to look. And again, there are charts based on cell studies and experiments that can tell you, oh, you should go to brigatinib, or you should go to lorlatinib, or alectinib after crizotinib. In other words, they can tell you propensities. That's assuming that there is a mechanism that's treatable. In other words, an on-target mechanism. So again, this is not as clear-cut as EGFR, but my opinion is this is where the future is headed in many of these cancers. In other words, not just ALK, not just ROS1, but many of them. Is you need to look. You know, you have a saying at GoTo, if you don't look, you won't find.
Yeah, it's very true. It's very true. And I know that's our mantra. And I think this is sort of a stop point really quick, kind of going off page, about why we constantly tell people who are diagnosed or their loved ones who are calling on their behalf, why it's so important. I mean, this is complicated stuff, right? It's so important for folks who are diagnosed to at least consult someone like you who has the opportunity to specialize in lung cancer, where lung cancer is your main area of focus. So you're able to attend these conferences, you're able to do the research, you have your finger on the pulse of what's happening right now, and things are happening like this, right? So if this meeting is not, proof, about why folks should really consider getting these second opinions, then I don't know what is.
I agree 100%. Most oncologists don't mind patients getting second opinion. They really don't. And if I were a general oncologist and the first patient I see is a colon cancer and the next one is a breast and the third one is a lung cancer and the fourth one is something else, it's very hard to keep up no matter how good you are. So second opinions are widely accepted. They're paid for through insurance. But here's where a patient advocacy group like GoTo comes in. Because if I were a patient and I had a difficult question like this, there's no easier and better place to go than an advocacy group like GoTo. Because Danielle, you and all the other folks that work with you there, you're experts. In other words, you've spent enough years, you go to the conferences, you hear the presentations, you listen to folks like me, you become very knowledgeable. And it's not to mean that you substitute for the second opinion, but very often you can give patients a guide what direction to go. So I think, that's invaluable.
Thank you. I appreciate that more than you know, and you are 100% right. We do not give medical advice, but we do understand where patients are and where they're coming from. So we can be an extension of care teams, especially, by helping folks with questions that they can then go back and ask their treating physicians. And I think I've told you this in the past. I've had patients before say, well, how come I had to come to you to find out what the right sort of pathway was to go, and share that with my doctor? Why didn't he or she know? And I always explain that this is complicated, and that if, to focus on the fact that they've actually taught their treating physician something that they can then carry on to the next person who walks in the door who's diagnosed with lung cancer. So, I think that we believe in this top-down sort of bottom-up approach to education, and that patients being empowered and educated on their disease is a very, very, very important part of this whole process. So I know you were just at ESMO. For those of you watching, that's sort of the European version, if you will, of ASCO, which we talk about all the time. So it's a big European Society of Medical Oncology conference. And I think you spoke on an advisory board about what my next question is going to be. And then we'll jump sort of out of EGFR and into some other spaces. But CLN 081. Non-small cell lung cancer patients with EGFR exon 20 mutations who had previously been treated with multiple other therapies. Can you talk a little bit about what was going on there?
The first thing for the patients who don't know what an advisory board is. So a company will, let's say, have a promising drug in lung cancer or breast cancer, whatever, and they get a group of people like me to give them advice. What do we like? What do we don't like? What are we concerned about their development of this? So the first thing you have to know is that everything we talk about is confidential. So I can't tell you what happened in that advisory board. But there are published data on the initial results of this drug, specifically in the exon 20 insertion, for those of you that might have that in your cancer. And in my opinion, again, not from the advisory board, but on what's actually already public knowledge, is that it is promising. And maybe one of the most important things is some of those drugs have toxicities. They're still good. They're good drugs, but that it could be more difficult to give. And this one, the initial data, it seems to be pretty well tolerated. So how it will end up, is it going to be superior? Is it even going to be equivalent to the other drugs? What will its role be in the future? I don't know, and I can't really say. But if I were a patient, and particularly if I'd had other treatment and now had progressive disease of my cancer, I would certainly go on a trial with this drug.
Another big area of focus that you've heard us talk a lot about here at GoTo, again, in this programming and other through our science and research department as well, is KRAS G12C. We know that a drug called sotorasib, aka Lumakras, I can say it even though Dr. Gandara can't, was approved fairly recently. And they are finding sort of some other subtypes. I think you mentioned a B53 and an STL11 and maybe something else that I can't remember. But can you talk a little bit about the biology different? And I think you had used one of your dating analogies with me on this as well.
Right, that's the co-mutation. So other mutations that are found with the main oncogene, and that's where I say it's kind of like dating. Anyone in this audience who had this KRAS G12C in their cancer probably knows about this drug. It's sotorasib. I call it SOTO, so I give everything a little abbreviation. So SOTO is a breakthrough. It is the first drug which can target this specific mutation. This is a very common mutation in lung cancer. In contrast to the ones we've talked about so far, this one is more associated with cigarette smoking. And because of that, it's what we call neoantigenic. That means that it turns on your immune system. So before we get to sotorasib, which inhibits the G12C, it's important for folks in this audience to know that if you have that KRAS G12C cancer, it tends to mean that you're going to do well in immunotherapy, because the immunotherapy is going to be able to block the inhibitory factors. One of these is called PD-L1 in your cancer and allow your own immune system to attack the cancer. And one of the predictors of that is G12C. Okay, so then let's move these new inhibitors. So for 35 years, paper after paper said KRAS is undruggable just because of the physical structure and the chemistry of the mutation, that we could find a drug against EGFR and HER2 and so forth and so on, but we couldn't here. So this is a breakthrough, huge breakthrough. And sotorasib is the first of these. Another one, adagrasib. They're both effective drugs. Neither one, well, I should say only one is approved, and that's sotorasib. It's not approved for first-line therapy. And part of the reason for that is what I just mentioned, that immunotherapy and immunotherapy combined with chemotherapy is highly effective in the G12C. So I often have patients ask me, or oncologists ask me, can I give sotorasib right off the bat? And at least right now the answer is no. You should go with immunotherapy or immunotherapy plus chemotherapy. Again, that's complicated how you choose between one or the other. But I wouldn't give this drug first, because you could have a cancer that goes into remission for years and years, with immunotherapy. That's the first thing to know. In terms of sotorasib, it is effective. I have a lot of experience with it. But ultimately, my opinion is that we will find combinations to give sotorasib with other things, maybe with chemotherapy, maybe with immunotherapy, maybe with other targeted drugs. And that's how we'll be using it in the future. But right now, it can be very effective in patients with this mutation. It also means that oncologists have to think about testing for this mutation. Because for years and years, of course, you didn't need to test for KRAS because there wasn't any treatment for it. Luckily, the broad, we call it next generation sequencing. So Foundation, Garden, all of these various tests, they all test for KRAS. So we don't have to test specifically. Somebody could be looking for EGFR and they'll say, oh, there's no EGFR, but oh, there's a KRAS G12C. So in other words, you'll find it like everything else. You got to look in order to find.
Increasing the rates of biomarker testing across the board are one of GoTo's main strategic goals. Like what role can we play in helping to make that happen? And we cannot stress enough the importance of this comprehensive or next generation type testing. So you're not just looking for single mutations at a time, but rather looking at the whole bucket, and not just of targets with approved therapies, but targets that are having some of these exciting results in some of these trials, which I think brings me to immunotherapy. I want to talk a little bit about some ASCO presentations that demonstrated some pretty beneficial results, with what you're talking about in this combination therapy instead of just IO alone. In particular, a little bit about lung map, which I know you are a huge part of, and some exciting trials that are going on there.
Well, we talked earlier about targeted therapy and what happens when the cancer becomes resistant. The same thing can happen in patients with immunotherapy, that if you're put on one of these immunotherapy regimens, that eventually the cancer becomes resistant. If you start off only with immunotherapy, then typically the next step is platinum chemotherapy, cisplatin, carboplatin with another drug. However, in a lot of cases, and again, this is complex, it's more beneficial for the patient to actually get a combination of chemotherapy plus immunotherapy instead of immunotherapy alone. So if you get both of them up front, that means what do you do afterwards? Because you've already used the chemotherapy. And here, we had a recent trial presented at ASCO that was part of Lung Map that explores these possibilities. And this is, to me, one of the biggest unmet needs in lung cancer is what do you do in so-called immunotherapy refractory disease, in other words, resistant disease. And in this trial, in terms of what would be the standard of care for somebody who'd failed immunotherapy, platinum chemotherapy up front, in the United States, more and more, that standard of care is a chemotherapy called docetaxel plus what we call an anti-angiogenic that affects tumor blood vessels called ramucirumab. We gave investigators in Lung Map a choice on our previous trial. Would they just give docetaxel alone, which has been around for a long time, or would they give it together with ramucirumab? And 2/3 said they'd give it together. So the trial that was presented at ASCO that Danielle was talking about randomized patients to get ramucirumab, but to get immunotherapy reintroduced with pembrolizumab, or to get the docetaxel and ramucirumab. And what the study showed is reintroducing immunotherapy together with this anti-angiogenic improved survival. Now, this was what we call a phase 2 random. So as you probably have heard, you patients, you learn these things. Phase 3 is like definitive. This was phase 2, but very promising. This has led to us, we're about to initiate a phase 3 to see if we can confirm it. This was one of 2 papers presented at ASCO. The other had another drug in it called cabozantinib. Dr. Joel Neal from Stanford was the lead on that abstract. And these are promising things to see, can we recapture cancer after immunotherapy like we're being able to do with targeted therapy. So there are lots of other things going on in this space, but I think that's one that's promising. I'll say it's considered investigational, right? In other words, it's not a standard of care. I don't know whether it'll be added to guidelines, etc.
So we've talked a lot about these sort of combination therapies, right? And adding drugs to other drugs to treat patients. And obviously in clinical trials, we're paying very close attention to, toxicity profiles and side effects that might be happening from some of this. But in your sort of opinion, how is using these therapies in combination changing the way we're thinking about how we're treating lung cancer and really, I guess, cancer in general?
Well, I think this is a double-edged sword. And what I mean by that is that if we have an incredibly effective therapy that can last for years in a patient with very little side effects, if you're going to give a combo that adds another treatment to it that adds a lot of toxicity, it better be a home run. In other words, it better be really more effective, because you don't want to take quality of life away from a patient. So we have this situation, for example, mirtinib. Should we be giving it together with chemotherapy in some patients? Should we be giving it together with an anti-angiogenic? And the one that's being tested there is the other one, bevacizumab. I won't say the brand name of it, but it's Avastin. So at any rate, all of those things are being investigated. But what I'm saying is, if I can tell a patient I'm going to give you a pill, most people are going to have very few side effects of this pill, and it's going to be fantastic for most people with your cancer. And if I can do that, and not add the chemotherapy or not add something else, then it's really, you better be sure that adding the other drugs and having more side effects and maybe decreasing quality of life, it better be meaningful. And the same thing is true for immunotherapy. Some patients have fantastic results just with immunotherapy by itself, without the chemotherapy. So again, it's not straightforward about who you choose one versus the other, but we're learning more and more about it. We have a huge trial ongoing that the cooperative groups, ECOG and SWOG, are doing together. It's called INSIGNA, and it's in immunotherapy. And we're saying at the end of the day, who lives longer? Is it okay to start with immunotherapy and then add the chemotherapy at the time of progressive disease? Or do you really need to give both of them up front? And we already have 450 patients on that trial. So eventually we will have the answer to that question.
It's fantastic. It goes back to the point we were making earlier about the importance of people talking to their physicians about clinical trials and when might be a good time for them to participate in one. But I do want to ask one final question. Speaking to this audience in our community, what is the reason, in your opinion, for folks to be and stay optimistic?
I think it's because the advances are coming so fast. There is no type of cancer where the advances are coming as fast as they are for lung cancer, particularly non-small cell lung cancer. I've had patients in the past where I treated them, they did really well, but eventually they died. And I said, I know there's something else going on here, but I just don't know what it is. That same patient today, and I can just list you the names. If that patient was today, I'd know what to do. That's the reason to stay optimistic. And a lot of my patients will tell me this. They'll say, get me through the next 6 months because I know there's going to be something else coming. And a lot of times they're right. And so that's the reason to be optimistic. There's incredible work being done all around the world. So hang in there.
Absolutely. I could not agree with you more. And I know, you know, that we speak one another's language when talking to our community about what's happening now and why it's important to stay hopeful. You guys see the word behind me every month. My take-home points are all obviously, I agree with everything Dr. Gandara said just now and has said tonight, but I do want to reiterate the importance of thinking about a second opinion with a specialist, somebody who is a key opinion leader and really has the opportunity to focus on lung cancer. I think that's wildly important. And I know we've sent a ton of folks to Dr. Gandara for second opinions, some of whom, you know, have traveled across the country maybe to do it and can still be treated, you know, at home by their local oncologist because Dr. Gandara is so great at sharing all of his knowledge with medical oncologists around the country and around the globe. So a huge thank you to Dr. Gandara for coming out yet again, all of you watching live or post live. Penn Media, who's working the back end of this, our go-to team. And last but absolutely not least, a huge thank you to our supporters. Without their generous support, we could not bring this and other programming to you. Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen, Merck, Mirati, Novartis, Regeneron, Sanofi, and Takeda. Thank you all. Have a wonderful rest of your evening, and we'll see you soon.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.